All right, let's dive in. Today, we're talking about one of the most amazing and honestly, one of the most vulnerable structures in our entire body, the knee. And look, it's not just some simple hinge. It's a true masterpiece of biological engineering, and it's right at the heart of the action in pretty much every sport you can think of.
You've seen it 100 times, right? An athlete plants their foot, makes a cut, and then they're down on the ground, clutching their knee. They say they heard a pop. That one sound, it can end a season, sometimes a whole career. But what does that pop actually mean? What does it look like to a radiologist staring at an MRI? Well, that's the mystery we're going to crack open today.
So to really get what's going on with an injury, we first got to meet the key players inside. Think of your knee as having a team of 4 critical ligaments that are responsible for holding the whole thing together. So let's meet the starting lineup.
First up, you've got the star of the show, the ACL, the anterior cruciate ligament. The easiest way to think about it is as the seatbelt for your knee. Its number one job is to stop your shin bone, the tibia, from sliding out in front of your thigh bone. It is absolutely crucial for stability.
Now, right behind the ACL is its powerhouse counterpart, the PCL, or the posterior cruciate ligament. And this thing is a beast. We're talking, hands down, the strongest ligament in the entire knee. It does the exact opposite of the ACL. It keeps that shin bone from sliding too far backward. Then, on the inner side of your knee, you've got the MCL, the medial collateral ligament. This guy is like a brace, resisting any forces coming from the outside trying to buckle your knee inward. But here's where it gets interesting. Unlike the ACL and PCL, the MCL is actually outside the main joint capsule itself.
And that brings us to the big aha moment. People always ask, why can't a torn ACL just heal itself? Well, here's why. The ACL and PCL are technically inside the joint, but, and this is the key, they're outside the little fluid-filled sac that bathes the joint with nutrients and blood. Because of that weird location, it just doesn't get the blood supply it needs to heal on its own.
Okay, so now that we've met the team, let's get to the main event. What happens when things go really, really wrong? Let's talk about the infamous ACL tear.
So the classic story goes like this. An athlete plants their foot, then suddenly stops and pivots. That twisting motion, it's just devastating. It can lead to something doctors call, pretty ominously, O'Donoghue's unhappy triad, and it's as bad as it sounds. It's a brutal, all-in-one disaster where you tear your ACL, your MCL, and your medial meniscus all at the same time. Now, when that ACL tears, the knee basically dislocates for a split second. And in that moment, the bones slam into each other, leaving behind a very specific bruise pattern that doctors call a kissing contusion. When a radiologist sees this pattern on an MRI, well, it's about a 95% specific sign of an ACL tear in an adult. It is the smoking gun.
Okay, so now let's put on our detective hats. An MRI is just packed with these subtle little clues, and radiologists have a whole playbook for spotting them. These little signs can tell you not just what is torn, but exactly how it happened.
Okay, check this out because this is so cool. Sometimes a tiny little chip of bone off the shin can tell the entire story. If that little chip is on the outer side, it's called a Segon fracture, and boom, that points to an ACL tear about 75% of the time. But if that same chip is on the inner side, it's a reverse Segon fracture, and now we're thinking it's a PCL tear instead. It's just amazing how one tiny detail changes the whole story.
And the clues just keep coming. Another telltale sign is the deep intercondylar notch sign. The best way to picture this is as a dent left at the crime scene. That same impact that causes the kissing contusion can actually leave a visible depression on the thigh bone. When a doctor sees that, it's just another rock-solid piece of evidence pointing to an ACL tear.
So we've talked about the ligaments, the ropes that provide stability, but the knee also needs cushioning, right? And that's where the menisci come in. These are the knee's absolutely essential shock absorbers. Now, a meniscus is this C-shaped wedge of cartilage, but here's the thing. Not all parts of it are created equal. The outer rim, what we call the red zone, has a really rich blood supply. That means if you get a tear there, it actually has a decent chance to heal. But the inner part, the white zone, has basically no blood supply. A tear there is not going to heal on its own, period. So when it comes to the meniscus, location is everything.
So what happens when these shock absorbers do fail? Well, just like with the ligaments, the specific pattern of the tear tells the doctor a whole lot about how bad the injury really is.
Out of all the different ways a meniscus can tear, the radial tear is one of the most serious. Imagine cutting a rubber band in half. It slices right across all those circular fibers, causing what we call a total loss of hoop strength.
That means the meniscus just can't distribute force anymore. It's functionally devastating for the knee and can lead to arthritis really quickly.
All right, now for a classic MRI sign, something radiologists call an ant mini, which basically means it's so obvious you should recognize it from across the room. It's the double PCL sign. This happens when a big piece of the meniscus tears, flips over, and gets stuck right in the middle of the knee. On the MRI, it creates this second dark line that looks exactly like a second PCL. You just can't miss it.
Here's another great little diagnostic trick. A normal meniscus on an MRI should look like two little bow ties, one after the other. But some people are born with what's called a discoid meniscus. It's shaped like a disc instead of a C. Because it's so much bigger, it shows up as 3 or more bow ties in a row. And spotting this too many bow tie sign is important because that disc-shaped meniscus is way more likely to tear.
So the MRI is read, the diagnosis is made, you'd think the story's over, right? Well, not so fast. The road to recovery after surgery is long, and believe me, it has its own unique set of challenges and complications.
Now, here is a wild fact about recovery that seems completely backward. You'd think that an ACL graft just gets stronger and stronger over time. But there is a critical vulnerability window. Between 4 and 8 months after surgery, that new ligament is going through a remodeling process where it is biologically at its absolute weakest. This is the exact time when athletes feel great and want to get back out there, but it's also when they are most likely to suffer a devastating re-tear.
And then there's this, a complication with a seriously cool name, the Cyclops lesion. It's basically a ball of scar tissue that can form in the very front of the knee after ACL surgery. It gets its name because when a surgeon looks at it with a scope, it looks like a single eye staring back at them. The problem? It acts like a doorstop, physically blocking the knee from ever straightening out all the way.
So how do you know if you have one? Oh, you'll know. The telltale sign is something called a palpable, audible clunk. The person can actually feel and hear a loud clunking noise every time they try to straighten their leg. It's a very distinct, very memorable symptom.
So, from that very first pop, to the tiny clues on an MRI, all the way through the long road of recovery, the story of a knee injury is just incredibly complex. The knee really is a biological masterpiece, but as we've seen, it's also incredibly fragile. Knowing everything that can go wrong with just one sudden pivot, does it change how you watch your favorite athletes push their bodies to the absolute limit? It's something to think about. Thanks for tuning in.